All right, everybody, I want to quickly go over the coagulation cascade. This should hopefully be a review from things that you've learned in your anatomy and physiology courses. There's two different pathways in the coagulation cascade. And it's called a cascade because just like a waterfall or water cascading over a rock, once you start it, it's going to just happen. There's not much that you can do to stop it from happening. So the first pathway is called the extrinsic pathway, and that is initiated when there's actual tissue damage. So the tissue, the vessel is torn and exposed to air. So that causes the release of a factor called thromboplastin, or more commonly tissue factor, which is factor 3. And then together with calcium, tissue factor helps to form factor 7. So it's just 3, 4, and 7, which leads to the creation and activation of factor 10. Once you get to factor 10, this is called the final common pathway because both the extrinsic and intrinsic pathways lead to the creation of factor 10. Once you get to factor 10, there's an enzyme called prothrombinase, which cleaves prothrombin into thrombin, and thrombin cleaves fibrinogen into fibrin. And fibrin is the whole point of the coagulation cascade. It's these thin filaments that are essentially scar tissue that are going to orient themselves to seal up and catch any elements of the bloodstream and pack them into this area of damage. The intrinsic pathway is, in healthy cases, activated by the extrinsic pathway signaling to this. And they work really well together so that when there is extensive damage, you need a good big clot, an effective coagulation. The extrinsic pathway tags the intrinsic pathway, which is going to create different factors, activates factors 12, 9, 11, 10, 12, 11, 9, it's clotting factor time, and eventually you get to factor 10. And then we're at the final common pathway again, making thrombin and then fibrin. So these are just different pieces that are needed to assemble or essentially knit these filaments of fibrin. They have to be assembled in the case of an injury. Clotting is referred to as a positive feedback loop, which means when one thing happens, it encourages more things to happen. So this is an example of like a cattle stampede. So let's say you decided to go cow tipping, and you're supposed to do that at night because cows are sleeping. So if you went in the day and you found a cow and you tipped it over, it's going to freak out and it's going to start running. And then other cows are going to see that cow freaking out, so then they're going to run. So then there's going to be more cattle running, more panic, and then it's going to keep going and going and going until there's this huge stampede and hopefully you don't die in a trampling. So it's something that happens and creates the possibility for more things to happen. So this is a positive feedback loop. A clot forms through the coagulation cascade essentially until it's filled the entire vessel. And then once it's occluded the entire vessel, then it starts to retract and kind of back up to allow some blood flow through there. But it just goes all in and fully overcommits itself. To make these coagulation factors, there's a couple of things that need to be inherently functional in the body. The first is that there needs to be a functional liver. In cases of liver damage, liver failure, you start to see clotting abnormalities. That's because the coagulation factors are created by the liver, and they're created by modifications to vitamin K. If you look at the table of different factors, you'll see the ones that are dependent upon vitamin K. Vitamin K is derived from these vegetables that when you cook them, they get really stinky. They're called cruciferous vegetables like cabbage and broccoli and Brussels sprouts and kale. There's also fortified cereals. So We're hoping that even if somebody doesn't want to eat these cruciferous vegetables or does not have access to those, that the fortified cereals will give them the vitamin K necessary for the liver to craft them into coagulation factors. So there needs to be adequate vitamin K intake and adequate liver function. Just a little note, things like the drug warfarin, it inhibits vitamin K. It's actually competitive with vitamin K. So it's actually recommended that individuals who take warfarin, or Coumadin is its trade name, do not have a large intake of vitamin K containing products because they can override the activity of that drug. Here are all of the factors. Again, you can take a look at where these things are made, so you'll see that like factor 1, factor 2, those are made in the liver. Prothrombin is vitamin K dependent. Factor 7 is vitamin K dependent. Factor 9, factor 10, those are all vitamin K dependent substances. The rest, they're really just made in the liver. So you have to have active, healthy livers and adequate vitamin K intake in order to have all of the factors necessary to create a clot through the coagulation cascade. And again, there are two different arms, the intrinsic and the extrinsic cascade, and both of them are going to lead to the same outcome, which is the creation of fibrin, this nice fibrin net. So there's a couple of different phases that you should know, because that's what the bleeding tests determine where the abnormality is. Phase 1 is really everything that is involved from the initial tissue injury to the creation of thromboplastin. So when you first cut somebody, you do this with like a bleeding time test, essentially. You take a lance to their finger and you see if they can form a clot and how long it takes them to form a clot. That's phase 1. Phase 2 is the cleaving of prothrombin into thrombin. So essentially you're looking for the body's ability to make the factors that cleave prothrombin into thrombin. Phase 3 is the creation of fibrin from fibrinogen. So there's different tests looking at phase 1 disorders, phase 2, and phase 3, and as we go through the pathology, they will be classified as phase 1, 2, or 3 coagulation disorders. Okay, so there's a song for this that I will post on Canvas, but the first pathway that's activated when there is true tissue injury, so that the vessel is torn, it's exposed to air, and there's danger of blood loss, that damage to the tissue is going to initiate the release of a factor, factor 3, thromboplastin, we refer to more commonly as tissue factor. And what tissue factor does is activate factor 7, which in turn activates factor 9. So we have tissue factor, which is 3, which is going to also need calcium, so that's factor 4, to activate 7 and 9. And then 7 and 9 form a complex to activate factor 10. Whenever you see white, so going from beige to white, that means that factor's been activated. It's been tagged. And once you activate factor 10, that activates the final common pathway, so you get the cleaving of prothrombin into thrombin, and thrombin cleaves fibrinogen into fibrin. And if you just have extrinsic pathway activation, there's a small amount of fibrin, little bit of coagulation, which is fine for small injuries. However, if there is a larger injury and we need a larger clot, factor 7 and thrombin's a really strong signal for positive feedback. They act together to signal to the intrinsic pathway to activate its activity. So we're going to follow the next slide in from factor 7 and thrombin, feeding forward to tag the next phase, the intrinsic pathway. So here we are, we've got 7 and thrombin, and they both come in and they have their own little job. So factor 7 is going to help activate factor 9. Thrombin activates factor 11 and also factor 8 and factor 5. 9, 8, and 5 are really important with regards to bleeding disorders, especially the hemophilia. So do keep them in mind. So 7 and thrombin will activate these important different pieces that will make eventually fibrin. So we've got 11, 9, 8, 5, and eventually we get to 10. And once we're at 10, again, final common pathway. Prothrombin into thrombin, fibrinogen into fibrin. And in this case, when we have a huge amount of thrombin, that's called a thrombin burst. The more thrombin there is, the more fibrinogen can be turned into fibrin. The more fibrin, the more effective the coagulation and the hemostasis. What we talk about in the next lectures with thrombi formation is we can also have this rogue factor, factor 12, which initiates the intrinsic pathway when it is perceived that the vessel is damaged without actually being damaged. So that would be a case where the inside of the vessel is really just nicked by a component of the bloodstream or something flowing through the vessel that just scrapes it, and then we activate this intrinsic pathway. This is not an advantageous way to do that. That leads to intravascular clots, which can lead to infarct, ischemia, strokes, heart attacks. We don't like that one. These other ones, these are good. They stop you from bleeding to death. So just putting those together, the way that these pathways interact, there's initial tissue damage. So you've got tissue factor that activates extrinsic pathway. Make a little bit of thrombin. Little thrombin is a little bit of fibrin, little clot. However, when there's a lot of thrombin, then that's going to signal to the intrinsic pathway to make even more thrombin. And the thrombin is really your positive feedback. The thrombin burst is what drives a huge clot being made. The more thrombin, the more activation we can have of fibrinogen being turned into fibrin, which is really just the sticky net to trap elements in a clot. The more fibrin you have, the more effective the coagulation. And that's what would happen in an ideal system where there's injury and we want to stop blood loss and there's no pathology and everything's working great. However, we're in patho, so we know that there's going to be problems. How do we stop these factors from going everywhere? A couple of different things. One is called antithrombin 3, which is a really straightforward name. Antithrombin 3 turns off thrombin so it doesn't go spread all over the body, antithrombin, and we don't have clots forming everywhere. Protein C turns off factors 5 and 8, which we saw are needed to activate factor 10 and go to the final common pathway. So if you turn those off, you're not going to go to the fibrin levels. Finally, there is a natural product called plasmin. So when it's time to make the blood clot go away because tissue is healing, we don't need it anymore, plasmin physically binds to the fibrin in the clots, and the fibrin is what holds them together, and it dissolves it. And when you dissolve the fibrin, it'd be like dissolving the concrete that holds bricks together. Now the bricks are just free to fall. So that's the way plasmin works. It binds to fibrin, dissolves it, and then the blood components are free to then move throughout the body. This is used in a prepared way in the drug streptokinase. If you've ever heard of a preparation of a clot buster, if somebody has positive symptoms for stroke, for example, they're taken to the hospital, they're given a clot buster, and one of the things that is contained in that medication is streptokinase. So if somebody does have a clot inside of a vessel, this is a prepared form of the natural substance plasmin that binds to fibrin, dissolves it, and liberates the blood vessel components so that we restore blood flow to that area. Again, final thing that you need to form a clot is calcium. You need it at every stage. Blood will not clot without calcium, but if you didn't have enough calcium to form a clot, you would not have enough calcium to have a heartbeat. So the only time you'll really have to worry about this is when you're in the lab, if you have to add calcium to blood samples to test coagulation. Okay. So this is where we'll end now, and then we'll go into the pathologies in the next lecture.